a Dr. House-inspired medical comedy with just the right dose of drama, sarcasm, and science. Today, our team of eccentric doctors, an overworked nurse, and one unlucky 10-year-old boy will take you on a journey to the twists and turns of pediatric acute glomerulonephritis. Except with banter, questionable bedside manners, and more kidney puns than you ever thought possible, all while actually learning how a sore throat can pick a fight with your kidneys. So here are our cast and crew. Now let's look into the case. A 10-year-old boy presents to a local emergency room with a 2-day history of pea-colored urine. His urine output has been below normal and his parents have noticed some puffiness around his eyes. On physical exam, vital signs are stable with exception of his blood pressure, which is elevated at 150 bar 100 mm per Hg. He has a periorbital edema and fullness of his abdomen with a positive fluid weight. The patient urine is grossly bloody. So now let's get started. Scene 1. At home. It's a calm morning in Ray's household until things start to change. A young patient is about to take his first step on a not-so-fun journey with his kidneys. In the kitchen, mom is prepping lunch and dad is sipping his coffee.
Hey, hurry up or you will miss your school bus.
Mom, my pee looks like coke.
What? Maybe it can go.
I haven't peed much and my eyes are puffy.
His eyes are swollen.
He's probably faking it. You are fine yesterday, right?
No, my stomach is filled. It's getting big too.
That's it, we are going to the ER.
Okay, should we put snacks too?
Triage assessment. At the local ER, Nurse Brenda is triaging patients with a signature attitude and defined IB of her own. In the emergency room, Nurse Brenda at the triage desk.
Next. What's your concern?
Ma'am, he has brown pee, his eyes are swollen and he's not peeing much in the past 2 days.
Let me see. What's your name? Age?
He just turned 10 last month.
Any allergies?
No allergies.
Any medications, prior illnesses and vaccination done?
Yeah, he's fully vaccinated and he just take paracetamol.
Sir, can you please fill up the address and the contact number? Okay, let's check the vitals.
Let me check your height and weight. Can you please come there? Yeah, so the height is 135 centimeter and weight is 32 kg. Can you please come there so that I can check your blood pressure?
Because of you, only my son is in this condition.
You cook tasty food in our home. Then why should we eat outside food?
Using me?
Nothing like this is hospital room.
No. My food are not.
So the temperature is 36.8 degrees Celsius and the heart rate is 96 beats per minute and the respiratory rate is 20 and O2 is 98.
And the blood pressure is 150 bar 100.
Oh my god, 150 or 100? This kid got better pressure than our waterline. Take him to Pedia ER immediately. Sir, please wait. Don't make me to triage you too.
The case is handed to Dr. Cameron and Dr. Foreman. History is where the magic starts, and in House's team, skipping details is a crime. Meanwhile, Dr. Chase handles the physical examination in her own way. In the ER room, Dr. Cameron and Dr. Foreman.
Hi, I'm Dr. Campbell. we just ask you a few questions.
10-year-old boy, low urine output with gross hematuria, periorbital edema, abdominal fluid, blood pressure is 150 over 100.
Oh wait, let's start from the beginning. Has he been sick in the past few weeks? Any kind of cold, sore throat or fever?
Just 2 weeks ago, he has a sore throat, no fever, and he's coughing and he's complaining like he has a scratchy throat. We didn't see it, and we just gave him.
Did he have any skin infections recently, like skin rashes or sores or infections?
Yeah, a few red marks is there, but it's like insect bites, and it's little bit itchy.
How about vomiting, diarrhea or any kind of abdominal pain?
No, actually, my stomach started to feel weird from yesterday. There's no pain, but it's
Have you noticed any changes in his energy recently? Has he been acting different?
Yeah, nowadays he is less energetic. Before he used to play like a crazy guy. Now he is little less energetic.
How's his appetite?
Poorly, he used to eat less, and he prefers soup.
Has he taken any medications in the past few days?
Just practical managers.
Any kind of allergies or any known medical condition or past hospitalization?
No,
Are his immunizations up to date?
yeah, fully well.
What does he usually eat? Does he have more salty food?
He eats more rice and fish, and he eats more salty chips, and he drinks lot of water, and he avoids soda drinks.
Has he traveled recently? Any contact with sick people? Do you have pets at home?
And no recent travel, and no contact with sick people, and no pets.
How is school? Does he get bullied?
He's not bullied, and no stress. Actually, he's a topper in the college, and nowadays only he is little bit less energetic.
Now Dr. Chase enters with a gloves and a slightly theoretical aptitude to do the physical examination.
Hello, I am Dr. Shiv. Can I proceed with physical examination for your son?
Okay, no.
Thank you. Alright, Matthew, let's sit up. Can you take deep breath for me? I'm going to look at your chest. I'm hearing mild crackles at the base. Looks like breakfast cereal commercial back there.
What are you talking?
Alright, okay, alright, Matthew. Let's lie down. Let me feel your tummy. Your belly feels little bit stretched and positive fluid wave. That's ascites. Looks like that swallowed a whole water weight. Now, let's sit up. Let me check your eyes. Looks like you lost a pillow fight with your own self last night, is it right? Two fluffy eyes. Let me check your hands and legs. rashes, and there is mild pedal edema. Reflexes are normal.
Oh, it's nephritic syndrome. Let's page house.
Scene 4. We enter the diagnostic war room. The sanctum where sarcasm is a diagnostic tool and the whiteboard has seen more dramas than a television. In the diagnostic room, House limps in, coffee in one hand, marker in the other. The team is seated with charts open.
Alright team, we have got a 10-year-old kid who is bleeding less, tea-colored urine, puffier eyes, and his belly filled with tanks of water. Let's find out who marked his kidneys.
This is nephritic syndrome, clearly of glomerular origin. Most likely post-streptococcal glomerulonephritis, given the history of sore throat 2 weeks ago, which makes perfect latency for the immune complexes to start bashing the glomeruli.
Yeah, the classic sequel, PSGN. The kidney is striking, strikes back, immune system activates, and complementary system drops down, and boom, the kid is being coked, right?
But we just can't settle on PSGN. IgA nephropathy is still on table. Kids get hematuria right after upper respiratory tract infection.
Yeah, right after, but his tea-colored urine showed up days later, right? IgA nephropathy is an impatient one, but PSGN is not like that. It's passive, but it's aggressive. It waits, stews, and then wrecks the place.
Still worth checking serum IgL to just to be thorough.
Okay, fine, let's add it to the list, but I'm not convinced.
What about rash on his legs? It could be HSP?
No abdominal pain, no arthritis, no GA bleeding. If it's HSP, it's on a beach vacation.
Yeah, he's right. And those rashes, do they look like mosquito bites? Never. Unless mosquito has renal specific venom.
What about lupus nephritis?
Maybe, but all pinoid kids hide rash under their t-shirt and hate sunlight. But ANA will be always negative. Okay, no problem. We'll check that too.
How about HUS? Because early AKI in kid and hematuria fits.
No diarrhea, no anemia, and no cystocytes. Platelets are fine.
What about membranoproliferative glomerulonephritis? Low C3, hematuria, and proteinuria fits the lab.
Maybe, but MPGN is an overacting one, right? It's a drag of chronic diseases. Same immune mess, but it's a drag of chronic diseases like hepatitis, endocarditis, or lupus. Here it's just a short story, not a novel.
Then what about nephrotic syndrome? Because edema is pretty dramatic here.
Nephrotic kids leak protein like a broken sack of rice. They have low albumin and usually normal blood pressure. Here we have hypertension along with RBC cast. This is purely nephritic erythema.
Yeah, he's right. Nephrotic syndrome has protein flat, but here it's hematuria. Okay, all signs showing up PSGN. So let's prove it with our labs, okay?
We'll order ASO titers, C3, ANA, anti-TSDNA, serum IgA, CBC urine analysis with microscope.
And maybe a renal ultrasound to rule out structural issues.
Yeah, right. Sure. Let's see whether radiology prints out heart over kidneys.
Cameron and Foreman march in with forms, Chase follows, sipping an energy drink. In the lab.
Oh, you guys again?
Yeah, and this time we want ASO, C3, ANA, anti-TSDNA, serum IgA, CBC and urine analysis with microscopy.
You know, it's a child, not a research friend, right?
Relax. Either this or we biopsy the kid.
45 minutes later, one spill centrifuge and a lab tech questioning test results.
See, I was right. ASO is elevated, C3 is low, ANA is negative, IgA is normal. Urine analysis show RBC cast and no cystocytes.
Oh, that's PSGN all over it. So strep really did it?
Yeah, it did it. Kidney strike back, throat punched kidney strike back, and immune systems got activated, complementary system dropped down, and finally it's PSGN. Okay, our final diagnosis is post-streptococcal glomerulonephritis. That's it, guys.
Case closed. One immune system meltdown, one very cranky kidney, and another day saved with sarcasm to spare. With the diagnosis in hand, it's time to fix what the immune system broke. But in true house situation, nothing gets done without at least one turf war. Dr. House enters like a rock star. The kid is resting in bed. Parents sitting nearby. Foreman and camera chase follow with clipboards and slightly blue stickers. A young nephrologist, Dr. Santos, stands by the bed reviewing labs.
Look, who called in these big guns? Nephrologists. They throw sciences when the kidneys doesn't do well.
We also talk slower, use bigger words and scare terms. I heard you ruled in PSGN?
Confirm. Elevated ASO, low C3, hypertension, hematuria, edema, RBC cast, classic PSGN.
Well, first things first. His hematology is stable. We manage conservatively and no biopsies needed.
Translation: let the kid marinate in antihypertensives and diuretics and no biopsy needed, okay?
Let me explain in simpler terms. About 2 weeks ago, your son had a strep throat infection. The immune system fought it off, but while doing so, it also created some antibodies. These antibodies combined with the fragments of strep bacteria and created immune complexes.
Is it like lumps of antibodies?
Exactly. These clumps of antibodies entered his bloodstream and eventually got deposited in the tiny filters of his kidney, the glomeruli. The glomeruli are coffee filters of the blood. Also, when these immune complexes large there, they trigger inflammation.
Inflammation means swelling, right?
Right. This inflammation tends to leak urine, RBCs and proteins, which is why his urine is tree color and is puffy. Also, kidneys tries to get rid of some of the fluid, which is why his blood pressure rises.
Is it permanent?
No, don't worry, it's not permanent. With supportive care and time, his kidneys will be completely alright. We will manage conservatively.
Unless he runs lemon strep takes time next month.
So, we will start with the low dose furosemide to remove excess fluid, and we will monitor his body weight, electrolytes, and urine output daily, and also we will give labetalol to reduce his blood pressure.
Low salt diet too.
Yes, less fluid means less water retention. Less salt means less fluid retention, and he will always be a fluid balance monitor.
Any role of steroids?
Only if this acanthtic or rapidly progressive glomerulonephritis, which is not.
And just to clarify, no antibiotics. The strep bacteria are long-term. These are the immune complex overreaction we are fighting, not the infection itself.
I know, sir. I also graduated from a med school, okay?
As the team nods, the treatment orders are written: furosemide IV, BP monitoring every 4 hours, salt restriction, fluid balance charts, and then gentle encouragement to the kidney to please do your job. Few hours later, Dr. House inquires regarding the boy in the nurse station.
Doctor, the urine output is picking up, blood pressure is coming down, kid started to improve.
Good. Then we don't have to do anything heroic, right? Boring is underrated.
Diagnosis nailed, kidneys recovering. Stay tuned for the next part. Scene 6. Dr. Santos, Dr. Chase, and Dr. Cameron follow up with the patient after a few hours.
Great news. He's going back to normal. His blood pressures are stable. We will discharge him now and take those medications, and you can follow up in 2 weeks.
You need to monitor his blood pressure. We'll be providing a PT cuff and a lotion.
Can you go back to school?
Yes, in a week or so, but no strenuous activity. The kidney is still healing.
And also, we recommend no added salt in his meal at least for a month, and make sure he recovers quickly. No rashes, no strep infections, and no tacos to the history meal. We also monitor his C3 and urine output in the follow-up. If everything tends to go down, we'll be totally fine. Don't worry.
And so ends another mysterious medical misadventure. 1 streptococcus, 1 immune system, 1 kidney, and 0 chip. Thank you.